All right, next we'll talk about lower respiratory tract disorders, and we're going to start with bronchitis. Bronchitis is usually viral, and a lot of people don't realize that. They think, I've got bronchitis, got to go get antibiotics. Usually it's viral. It's inflammation of the large airways, and usually it's descending from an upper respiratory infection. So they have a cold, moves down, and the bronchi get inflamed. It begins with a dry hacking cough that becomes productive about 2 to 3 days in. It's self-limited. It can be associated with COPD. So patients with different types of COPD are more likely to get bronchitis. It can become chronic, especially for those COPD patients. Adolescents with bronchitis should be assessed for tobacco or marijuana use. Nursing care is promoting comfort, humidify and hydrate. Cough shouldn't be suppressed. They want to get this stuff up, and teaching that antibiotics are rarely needed. Next is bronchiolitis. Usually this is caused by respiratory syncytial virus. So we talk about RSV. It's transmitted by contact with the secretion, so droplet contact. The pathophysiology. So the ciliated cells in the respiratory tract swell and lose their cilia. Remember, flu does something similar, but these aren't killed, they aren't damaged, they just swell and lose, or not destroyed, sorry. They swell and lose their cilia. The walls of the bronchi and the bronchioles are infiltrated with inflammatory cells, and so that narrows the airways. They have swelling, they don't have cilia to sweep things up, they have increased mucus production, and it's this clear, slimy, thick mucus, and there's so much of it, and their airways are constricted, and so their airways are narrow, and they have air trapping and overinflation. So this begins with an upper respiratory infection, but remember, it's usually an RSV, and it may or may not progress to the bronchial. So it starts in the nose and throat, moves its way down. And on assessment, they may, when you listen to their lungs, they sound wheezy and crackly. And they'll sound like that for about 3 weeks, no matter what you do, wheezy and crackly. They have retractions. They may have dyspnea, tachypnea. They may have diminished breath sounds. The secretions are profuse, and it's clear, slimy looking secretions. In very young infants, they may not have all these symptoms. Remember, their immune systems aren't responding well to everything yet. And so the first symptom that they may have is apnea. Medical management. For diagnosis, respiratory secretions are tested for the antibody. This is self-limited. It does last 2 or 3 weeks, but it's self-limited, and supportive care is the treatment. If they can't maintain O2 sats, they need humidified oxygen. Chest PT and postural drainage aren't recommended. They don't help get the stuff up, and they can cause more airway spasm. Some providers will use racemic epi or other bronchodilators. There's controversy about that in the literature about whether it works or not. Same thing with systemic steroids, IV steroids. Antibiotics are not recommended unless they also seem to have a bacterial infection. High-risk patients get ribavirin. It's an antiviral specific to RSV. There's a monoclonal antibody that can be given to high-risk infants monthly during RSV season. And so some kids who were born premature may get monthly antibody injections. They think of that as a vaccine. It's not really a vaccine. They're adding an antibody, so it's artificial immunity. RSV can be managed at home if the child is stable and the family is able to give them appropriate care and monitor. Kids who've had RSV are at risk for wheezing and asthma in the future. Nursing care, contact precautions, maintain their airway. These kids require regular bulb suction of the nose, clear out their nose frequently, monitor their respiratory status, maintain O2 sats over 94, promote hydration, comfort, and nutrition. Okay, next section will be about pneumonia.